tried to put together most of the information you received today in another aspect of the practice of rabies, which is the indication of post-exposure prophylaxis and pre-exposure prophylaxis, and we call it generically human rabies prevention, human prophylaxis. This slide is a disclosure, but give me the opportunity to mention something. Recommendations evolve. Because recommendations evolve, some of the members of this important set of people working on rabies, as industry, public health sector, private sector, insurance, they have to synchronize together in some point. They have uniformity. In the second disclosure, you can say that we got some change in the ACIP. The ACIP is the National Committee of Immunizations in the United States. I want to commend that because it's still synchronizing with the rest of the members of the rabies prevention action. But first of all, reminder what we want to get with human rabies prophylaxis. We want to prevent rabies before it starts. The incubation period has been mentioned across these talks related to when to test, when not to give PEP if symptoms start. There was even mention related to animals. But we want to prevent rabies and give this prophylaxis before this clinical signs of rabies start. So the next item says we need to have a risk assessment. A PEP or PEP or whatever of the schedule we choose for prevent rabies, it is not a simple, easy decision that anybody can take, like in a kiosk, and oh, I want to get this prophylaxis because I think. You have to go through a risk assessment. There is a set of indications. Some of them have been already reviewed. And also, if the risk assessment established you need to get the prophylaxis, then we shouldn't delay the administration. As I already mentioned about clinical signs, might confuse diverse types of encephalitis, and we don't know if it is rabies or if it's not rabies. The only suspicion of rabies in the differential does not get the indication of PEP. We need to get the proper ante-mortem testing, and we determine this patient has been exposed, have clinical signs after a few weeks that might be rabies. They send the samples to CDC, and ante-mortem testing says this is not rabies. Then this person has been exposed, might develop rabies anyway, and then the indication is established, for example. Another mention, ACIP. ACIP is the committee that reviews all these recommendations. It's a scientific committee that takes very seriously any change, any update, any information they can provide to the public and to the state. Here we have a summary of many of the terms that were mentioned during the day in different conferences. So we can see new ones, but we need to refresh a little because this is the common language you have in the clinical setting with the patient or indication, or to interpret a little the ACIP recommendation, which is a publication that is online. You can download it. It's open to everybody. So PEP, we know is post-exposure prophylaxis. Pre-EP is pre-exposure prophylaxis. It's obvious. One is before exposure. We don't know if the exposure is going to happen or not, but it's likely. And PEP is post, when the exposure already happened. ACIP is the Advisory Committee on Immunization Practice. Again, this is a national group that review all the recommendations for any vaccine in the United States. It's a very high reputation committee, and everybody uses technically for the decisions in hospitals. However, we found out that many of the emergency room doctors or people don't really review in detail or don't know about this document, which uses a reference. So we receive consultations a lot about, and we guide people in the internet to download the document. But this is a reference group that review all the changes, all the new things in vaccine. IM, intramuscular injection, ID, intradermal injection. Those are the two approved, WHO approved ways to administer vaccination. Rabies vaccine, ml, milliliters, so this is how we measure the vaccine. International units, another important measure for calculating immune globulin doses or also vaccine potency. HRIG, human rabies immune globulin. Lilian reviewed this morning about the virus neutralizing antibodies, and this is a term we use to make some decisions. You can also see here the RFFIT is the test for antibodies that we use, especially when people already received vaccination in the past. I will mention that during the presentation. Well, we know, as I said, something has to happen, a spike that produces a lesion that might allow entry of the virus, the rabies virus, into the system to start to suspect this is an indication for post-exposure prophylaxis, yes or no. Dr. Rupert just explained very good many situations that lead for a proper evaluation of each case individually. So the rabies risk assessment is not a general one solution situation. You have to examine the case one by one, and you find out different answers for each situation. Three components are very important, and we have to mention all over, because we all will remember, oh, post-exposure prophylaxis is the vaccine plus immune globulin. But watching the lesion is one of the most important, easy, and immediate components of the post-exposure prophylaxis we can do. So watching the lesion for 10 to 15 minutes with soap and water, scrubbing it with some energy, can actually reduce the amount of virus that has been inoculated in the system. This is especially very important for developing countries, that in many places, as we mentioned, that it's going to take some time to reach the medical service to get any PEP indication. So, as a general education message, is washing the lesion 10 to 15 minutes with water and soap will actually reduce a lot the risk for rabies, and actually will be the first element accomplished that we cannot skip in any exposure for rabies. Then you have the next component, the human rabies immune globulin. There are actually two immune globulins. United States only use the human immune globulin. You can hear and read about other types like equine immune globulin that is used in America, for example. And you calculate 20 units per kilo weight. I will comment later. We have some consultations of mistakes. Sometimes they miscalculate and they only put 1 ml of immune globulin when they have to calculate the volume according to the product and the weight of the person. So this is very important. 20 international units per kilo weight. There are some tables that actually show by the weight in pounds. You can actually find on the internet, and some conversions to be done. But this is something to remember. The volume of immune globulin is always variable. There is a factor that changes, which is the size and weight of the person. The volume of the vaccine, opposite, it doesn't change. It's 1 ml in each dose, and in the current recommendation for United States, it's 4 doses in day 1 dose in day 0, day 3, day 7, and the last dose in day 14. And for people vaccinated in the past, let's say somebody got exposed today and next year get exposed again, we do not have to start all over the PEP. We only indicate boosters. There is no need for immune globulin again, and there is no need for the 4 doses, just 2 doses, day 0 and day 3. Here is the table, which is in the ACIP document. As I said, there is some things that, well, this is marking this is wrong. What actually happened is that this is indication of day 0, day 3, day 7, day 14, and day 28 from the previous recommendation that includes 5 doses. This recommendation has been updated, and there is a special document that changed this table, but the table you will find on the internet still contains this 5th dose. But you have to rely on the update that has been published in MWR, and by ACIP that actually updates it, not anymore 5 doses, it's 4 doses. So just remember this, when you have access to this table, there is an additional document that has to be attached until the new fully revision of the recommendation is published during this full correction. So this table, there's a lot of words here, but review whatever we already explained, just to remind, watching the deletion is many times forgotten, but it's here. It's written, it's there, it cannot be skipped, it cannot be ignored when the physician explains the risk to the patient. It has to be asked, and we have to find out if this part, this component PEP actually has been accomplished, and when. About the PEP indication, there are some considerations here. For exposure to dogs, cats, and ferrets, we still we have actually an advantage. We can observe the animal for 10 days, which means that we have to give the PEP immediately after the exposure, and the answer is no. If we have the animal, and this animal has attacking the person happen to be a dog, cat, or a ferret. So we do have these observation periods only for these 3 domestic animals, and we have theoretically the time to decide if this person needs or not need to receive PEP. Earlier in this session has been mentioned that in very intense exposure to face and neck, you can actually take the decision to start PEP while the observation. In this highly suspicious exposure, you can start and stop when you have the testing or the observation of the animal reveal this animal is healthy. This is something to remember, and bring us back again to the situation that not all the cases are resolved exactly the same. What happens when we do not have the animal available? It happens to be a dog. What happens when the animal is the owner of the animal saw an incident and take the dog and bring it away to another state? We lose the dog. We lose the ability to test or observe this animal on time to decide PEP use. And in those cases, when the animal is not available, even when it's dog, we actually go ahead and vaccinate. This is the only disclosure, but this is something we have to remember, because we still receive consultations that reveal that many of the physicians, sometimes they go ahead and start PEP and they don't do the observation period. So we have to consult all this knowledge that is very common for veterinarians, with the knowledge that doctors have, because sometimes in matter of time they want to resolve the case fast and easy, and we do not want that. For skunk, raccoons, foxes, and most of other animals, carnivores, if the animal is available for testing, we can't wait. We have to wait to have the results of the laboratory to decide. You can have consideration for immediate prophylaxis. Yes, if the animal is not available, if the testing is going to take too long, if shipping samples to a laboratory is going to take 5-6 days, or there is no guarantee of response to some other laboratories, after so long waiting time, we probably need to consider the start of the prophylaxis as soon as you can. So all these situations have to be evaluated case by case. It will not be the same an exposure happening in Atlanta, Georgia, in the metropolitan area, versus an exposure probably happening in Montana, miles away of the closest laboratory of medical service. About livestock, there are some considerations to say here. There are mentioned to rodents. Rodents exposure has been already explained. This is a situation that we receive every day, confusion about physicians indicating PEP for rat bites. Even in this conference, I have a discussion with another colleague from an American country that say in the country, any rat bite is immediately sent to PEP. So we have to think about that, and I'm really thankful for the discussion earlier about this, because there are some situations that can be discussed about the animal, but in general we do not have evidence that a rat or a mouse bite can transmit rabies, and we don't have actually information that this actually happens. About pre-exposure. Pre-exposure is the other side of the prevention of rabies. You need to have a specific indication when to administer or request pre-exposure. For people working in laboratory, it's very well known before you handle any rabies virus, you are supposed to be vaccinated. Otherwise, you cannot be in contact with any contaminated sample that might put you at risk. Another consideration is travel. Places as India or other places with high incidence of rabies exposure and rabies cases in animals, we know that if you want to be in areas, rural areas, and you have high likelihood to be bitten by an animal, might be rabies, then the indication might stand and you can go and receive your pre-exposure, and pre-exposure is only 3 doses. We do not need immunoglobulin. Remember, the exposure did not happen. We are trying to prevent before the fact. The vaccine, or I didn't mention the other, the vaccine is given intramuscularly in the arm. Again, same than people vaccinated from post-exposure in the past. If you get exposed in real, you do not need to start the full treatment. You only need one booster in this case. And also for people working in laboratory, we need to test them regularly, and the recommendation is that people, as veterinarians in contact, daily contact with animals potentially infected, and people working in laboratory with rabies samples have to be
2 if exposed.
2 if exposed,
1 for booster.
1 for boosting routinely, 2 if exposed.
Yes, that's correct. That's correct. That's exactly what's going to that. Yes, the booster, if you have a real exposure, you have to get what we know, the post-exposure booster. That's the indication when you get exposed. So it will be a post-exposure booster. If you have not been exposed, then you get the booster as a maintenance. But this booster will be dependent as your antibodies are testing below 1 to 5 in the RFFIT test. This is very important because in some laboratories, yes, they do have the prescription. This is 2 years. This is your time to get your booster. If you have the access to the test of the antibodies, the antibodies have to be taken, and the decision for the booster will be depending on the results. Observation is that in many cases, actually I'm not aware, people many years working in the field, they actually get antibodies below this level, but in the eventuality it happens, because it is not something that has not been seen before, then the booster has to be indicated. And then they continue the evaluation in the next 2 years. I think laboratory is 6 months evaluation for people working with everyday rabies infected samples. So again, there is a table in the ACIP. It's the same situation, primary vaccination, day 0, 7, 21, and 28. It's an election or convenience. And the vaccines are mentioned here. I will actually expand more in the next slides. But we have the 2 ways to get the prevention prophylaxis treatment, as they call it. The indication, again, already mentioned, most of these for people working in continuous exposure to the viruses, testing every 6 months. Frequent exposure as veterinarians in the hospital, animal hospitals, testing every 2 years. Primary course for only for infrequent. You're gonna travel, you're gonna get some contact with some animals temporarily. You can get this pre-exposure for first time. Maybe you might not need a booster ever or testing. And the other very important thing, the indication of booster and testing only stands if your occupational exposure actually persists. If you stop working in laboratory, you don't need to get additional evaluation, and you became part of the general population. And you have to remember, if you ever get exposed, report your previous vaccination. Another common situation is some people being vaccinated in the past in some areas or some hospitals. When they see a new exposure, they indicate a PEP de novo. This is another situation. It's not rare to constantly we're trying to share this information so these mistakes are not repeated. Well, what happened? What do we have as biologicals in the United States? There are 3 vaccines approved by WHO. 2 of them are fully licensed in the United States, which is the human diploid cell vaccine and the purified chicken embryo cell vaccine. Both vaccines use the intramuscular administration way, and both vaccines are easily accessible in the market. One thing to remember on both vaccines is one vaccine is doing with eggs, another vaccine is doing in culture cells from humans, and that might have an impact in the decision when somebody has allergies to eggs, for example. So it's an advantage of the population to have at least one alternative if you have one allergy event observed after vaccination. This is the product just to show how physically is. Many people don't have access to see, only the nurses. You just go to the ER and then you get the syringe with it's already loaded. But the vaccine is actually came in 2 vials. One is the solvent, the other is the lyophile component, and they actually merge when it's needed. And you actually have 2 needed, one to reload the solvent and one to administer the vaccination. So it means that this is a vaccine that cannot be administered just by anybody. It has to be followed the recommendation of the proper hospital regulations that can be administered by licensed nurses or proper people in the ER. The other product is the same, both are similar, both have the same advantage. The difference is one have egg component, the other is different type of cell culture. I mean, chicken embryo cell vaccine. No, this one. Let me see. Yes, this one. Okay. The rabies immunoglobulin. What's happened that in the US there are also 2 products you can choose from. The advantage or disadvantage are not apparent on this. It's just availability and whatever the hospital has available. Both are human immunoglobulin, and both are, I think, easily accessible in the United States. We don't have any problems or reports of lacking of this so far. The presentation is that these vials. The reason to have different volumes in vials have something to do with the size of the people. It's not the same giving immunoglobulin to a little child, 5-year-old, to a 50-year-old lady that might have different weight and different sizes, and you might need more volume. And you also, I mentioned this, but could be a very skinny person too. Doesn't mean that it's just the size, change the weight. So, but you need to remember, we need to guarantee the immunoglobulin actually reach the muscle. It's intramuscular. We have a lot of issues of immunoglobulin administered in different places that might not reach the muscle. What happens with immunoglobulin is that because we have to administer 20 units per kilo, the volume can easily exceed 10 ml. If you exceed that, you cannot put the whole volume in only one injection. So the recommendation is that if the area, the lesion is obvious and the exposure is recent, you inoculate the area of the lesion, at least if you can, with 50% of the volume around the lesion, as much as you can. If you cannot do that, because volume can change, it's too much, you have to choose different parts of the body you can access in the legs, in the thigh, and the arm, but you always avoid the same arm that you want to give the vaccine. That's very important, and this is another very common mistake. Sometimes vaccine immunoglobulin in the same arm, a lot of volume immunoglobulin that neutralize, that really interfere with the vaccine effect. Again, they present the pictures and the inserts of the vaccine, also from the immunoglobulin, just to make you familiar. Sometimes no easy access, but this is also on the internet. Also to show that it's all FDA approved, there are no problems or issues with any of these products. Intradermal vaccination is not licensed in the United States. I just mentioned this because those intradermal schedules are actually recommended by WHO. In the future, probably not a near future, might be considering the US, but in more closer future, might be considered for other countries in Latin America, and there will be more consultation of people traveling back and forth from those countries that might receive this vaccine, and we might not need to be aware that intradermal has a specific schedule, not the same that intramuscular administration. Common deviations, we already mentioned some of those. Incorrect indication of PEP, very common. So I think I'm going to work with animals because I'm going to the junction for 1 week and I need pre-exposure because there is a lot of mongoose. I'm going to the ER and really pressure my doctor to give me the vaccination. So doctor has two choices. Tell the truth, you do not need it, or comply and pass the bill. And many doctors do that. They actually comply with the patient, but it's something that might be done in their own room, consultation room, but it is not recommended. Indications of PEP, like starting PEP without waiting the 10 observation period when you have an own dog in your own house, for example, or own cats or ferrets. The same vaccine of immunoglobulin given subcutaneous, that's the other problem. Fatty tissue is not a good place to do the immunoglobulin, already mentioned that. So gluteal areas, lower gluteal areas are not recommended for the injection. We have actually consultations of problems with the dose of the immunoglobulin. It's not extremely rare, it's infrequent that sometimes they invert the vaccine. Actually, at least I heard of one case that somebody put the vaccine by kilo weight volume in excess and the immunoglobulin only 1 ml. So these things could happen even in the United States, but it's good to remind that it's two components of the PEP needs to be properly observed. We already mentioned that they use the same arm for all biologicals. Some patients actually just skip one dose and they came back later. It was already discussed. Vaccination should continue to completion when the indication stands. Immunoglobulin, this is another very common problem. Somebody received the vaccine, started treatment either in this country or another, and showed up 5 days later, and the doctor said, shall I still give the immunoglobulin that was not available at the time? We recommend that if actually it's in the ACIP, the first 7 to 10 days, you still have the time to give the immunoglobulin. But if you show up 2 weeks later and the vaccine becomes available in the hospital but took too long to get there, it's not necessary anymore because your own system already reacted to the vaccine and they do have enough antibodies that will be actually interfered by giving the immunoglobulin. That doesn't make sense anymore. So this is something to remember. Delaying the immunoglobulin has to be examined carefully, and if it's more than 10 days, there is no need for an indication anymore if the vaccination has been initiated. Okay. I mentioned for travel, there is a lot of consultation of people starting a PEP in India, in Latin America, and sometimes they receive vaccines that are not licensed in the United States. This is a very common and important consultation. For example, somebody is being in Colombia and being bitten by a dog, and then start vaccination day 0, 3, and 7 with Vero cell vaccine, which is a WHO recommended vaccine, and came to the United States. Somebody started vaccination in another country, receiving nervous tissue vaccine, like in Ethiopia or in Peru, and they came back here after halfway of the treatment, and those vaccines, nervous tissue vaccine, are not licensed in the United States. This is a problem. In general, WHO recommended vaccines. We can continue the treatment with the licensed vaccine in the United States. Non-recommended vaccines, we start the treatment, the full post-exposure prophylaxis de novo, including immunoglobulin. Already mentioned this too. When people came from other countries with whatever vaccine and they complete the treatment in the other country, we still have consultation. Was the vaccination okay? Yes or no? Well, we know this vaccine is in good condition. We know this vaccine is WHO approved. We know the schedule has been respected. carefully, so we don't think it's a problem, and we explain the patient or the doctor according with all the regulations, also in another country, but WHO recommended. We don't think this is a problem. But if we do think this is a problem, because there is no guarantee, there is no documentation of this vaccine, this is another very important situation. Some people came from another country. I think somebody came back from Azerbaijan with some local language certification of rabies, and nobody ever could read it in the hospital. So it was no clue what actually they received. It was tetanus vaccine, it was antibiotics, it was something. So in those cases, we have one option. If the risk is too high, we probably need to start vaccination, the PEP. If the risk is medium, it is not real. Sometimes many people abroad, they actually start the PEP. We can take a sample, serum, send it to the lab and get the antibodies, calculating if the treatment has been completed at least for 2 weeks after the last dose. So with those alternatives, we can actually answer the patient, okay, your antibodies demonstrate you receive a vaccine and you seroconvert and you are okay, even if the vaccine might be unknown, but we have enough evidence that you receive something that induces your immune system and you are okay. So I think that's very much. So we'll have some time for questions now. Okay, 3 questions. The ladies' questions?
Thank you, ladies first. So thank you for your presentation, Dr. Recuenco. And I have a quick question. Is there a list of countries that do not use WHO approved vaccines for us to have easy access? Because a lot of times the patient does not know, and perhaps we are not familiar with which countries use WHO approved vaccines or not.
Thank you very much for your question. This is a very important question. If it would be an easy list anywhere on the internet, on the iPhone, then you don't need to ask this question. We don't know. We receive consultation from doctors because nobody have a clue what is the vaccine they are giving in Iraq, in Sergio, because somebody been 5 years later need to get vaccinated, what vaccine, yes or no. And actually we have a lot of time sometimes invested to chase that information and compile it. As soon as you compile something, situation changes. You have to call all over again. That's why we have a network of point of contact all over the planet, so we can call immediately and get answers. We get questions about, my daughter has been in Ecuador and is coming back, is this a good vaccine? Well, sometimes I know because I'm familiar with those countries. Sometimes we have no idea what's happening right now in Benin, if they do have vaccine in the pharmacy or not. So for Latin America, there is a document that came up every 2 years from the meeting Redipra. You can find online. You can read the reports and have indirect information. What vaccine might be induced, yes or no. But most of the time have to be case-by-case daily consultation to see the real current situation.
And as Emily Genti's presentation this week demonstrated, this is a moving target. It's dynamic, that we oftentimes don't have that information. So relying upon information may be outdated, inadequate, or even if it seems accurate, you don't actually know what that patient got. It could be antibiotics, it could be tetanus vaccine. They got something, whether it was rabies vaccine or not.
Thank you very much for reminding that. Was one of the most interesting talks about vaccines, because there is a lot of self-declaration of the vaccine has been received in countries where we don't know that vaccine does not exist. That was really very interesting to see how the disconnect and perception might not match the reality.
Which has led to at least one case where a patient got something, but what they got, nobody knows what it is, and in fact, rabies was the consequence.
Another thing that it's very common is that when you have somebody say, oh, I went to, after the bite, I went to the ER and received 2 shots. I say, oh, that's great. PEP, immunoglobulin plus vaccine. When you ask more, it's tetanus plus antibiotics. Sometimes it's nothing like that. So we need to get proper documentation, and this is a challenge because not always the patient have the education or time or care to get all the proper paper when they travel or when they even are in country.
Very nice presentation. I know that rabies is different than the measles and chickenpox, you know, that we do vaccine efficacy studies when we have outbreaks. There's not that many people who get human rabies, but has there ever been a study done that really proves vaccine efficacy for the rabies vaccine? And if it has been done, what is the percentage of efficacy for vaccination?
Well, actually, the question is, if having ever studies that actually document the efficacy of the vaccine, meaning seroconversion, right, among general population? Immunogenicity. Okay, referring to immunogenicity and levels of antibody. Well, all the companies, when they produce the vaccine, even locally produce vaccines, most of the time they have clinical trials and they choose different type of populations. AACIP is very explanatory in the document what is the evidence of immunogenicity of each of those vaccines that has been licensed in the United States. So there is a set of reference, but most important is the set of explanations that there is no contraindication because we don't expect problems in pregnant women, we don't expect problems generally in children, but all of the studies in the doses recommended, we expect 100% of the population to have proper immune reaction.
Irrespective if it's an older person or if it's a person is immunosuppressed, you have 100% vaccine efficacy? Well,
with some consideration that would be correct. I mean, people receiving immunosuppression treatment like cancer or receiving steroids for other medical problems, we recommend to stop, as I think was mentioned earlier, to stop the treatment for 2 weeks at least, so we can administer this PEP and induce an immune reaction, okay, so this person can actually be reacting or defend against the exposure. I'm not really aware, actually I will probably of only one situation that in HIV, even HIV patients receive, and there are no problems with that. There might be apparently problems in some cases, but when you examine closer, they did not stop the medicine, and when they actually stop the medicine and they start treatment, the the immune reaction is fine.
In fact, one could reverse the question and ask, at least for the products that are licensed in the United States post-1980, for either pre or post-exposure, by intramuscular route, the number of human rabies cases that have developed post-1980, given 30,000 people per year since 1980 or more receiving pre or post-exposure prophylaxis, what is the number of human rabies cases that has been documented?
Thank you, Dr. Lopez. Dr. Lopez pointing out the very strong epidemiological evidence that after 1990, we did not 1980s, the introduction of the modern cell culture vaccines and immunoglobulin in the PEP, we did not observe any rabies cases in people receiving either PEP or pre-EP. So this is kind of the evidence we handled to explain that if there were any problem in the immune reaction induced by those vaccines, we should have observed in these 30 years some at least few cases. We did.
Is post-exposure prophylaxis failure in the world with modern cell culture and immune globulins, whether they be heterologous or homologous, how common are true post-exposure failures in the world with modern rabies biologics, given that if the estimate of the burden of exposures in the world is somewhere in the estimate of 10 million per year, how common are post-exposure failures with modern biologics in the world today?
Well, Dr. Lopez is asking, with all this number of doses of vaccine, modern cell culture vaccine given in the world in millions, how come we didn't see any vaccine failure?
How common? Is it failure common?
No, there are some reports on failure of vaccine, most of them from Asia. Actually, there is a very interesting paper that is no more than 1 year that examined more than 15 so-called cases of failure of vaccine. When they examine the cases, most of them, almost all of them, are deviations of the PEP, which means it's not a real failure, it's a deviation that ends in a rabies case because they did not follow the proper recommendation. the real true deviations are still the real true failures are still controversial, and they are standing no more than 2 or 3 cases, at least in the review, for more than 35 years. So you can, I don't know, have the reference with me. It's very easy to find it on PubMed, but that's a very revealing set of so-called failure vaccines. So with the introduction of modern cell culture vaccines, we really have a lot of confidence that proper scheduling, proper recommendations, we do not expect failures in any country in the world.
Good presentation. Along that question, and also with the WHO question, with regards to developing country that is also very hot nature in the hot environment, how viable are these vaccines? Are they cold sensitive? Because the vaccines we have in the United States, you can refrigerate it, but in developing country where you don't have refrigeration going on, are they
Thank you very much. That's an excellent question. Can you remind me your name? You are from San George University, but I want to say your name.
Keku.
Dr. Keku. Well, the question is that what is the consideration regarding with cold chain for the vaccine, especially tropical countries where it's so hot, in the climate is very adverse. So, or the opposite, in very cold areas of the world, that the vaccine could be frozen. Well, cold chain is very important. The good thing is that these vaccines, if properly handled in the range of the refrigeration, which is, I remember very well, is 2 to 8 Celsius degrees, if it's maintained like that, which is similar to the children immunization vaccines. So if they are maintained that way, we should not expect any problem. I would actually add the large success in tropical countries on polio vaccination or measles vaccination tell you the answer. It is possible. So
or one could ask the question, it's hot in Latin America.
Very much.
How common is post-exposure failure in humans in Latin America?
Yes.
As a Latin American, what's the answer?
The reference is pointing that with the very hot weather in Latin America, how come we didn't have any problems on cold chain that are really noticeable and well known? Well, there is a good experience in the public health setting, and I think
when done appropriately, when people work together, when people know what they're supposed to do.
So everything properly done shouldn't expect any problem.
It's a political will question. It's not an issue of technology. It's not a question of a developing country.
I will add some more that the big problem will be for really far places, very isolated places, which is not the same situation for Puerto Rico, Colombia, maybe the far remote areas of the Amazon, as in some point I discussed. Some additional techniques and strategies have to be developed to maintain the cold chain, which is the same paradigm. We keep the vaccine in those temperatures, we shouldn't have a problem, but the logistics might be challenging.
Right. See, that's what I have problem with in terms of, if you go, for example, in Africa, if you go into the most remote area where there's even no electricity, and some of these even semi-developed countries in Africa, you still have electricity that is being taken away, So if you have all these vaccines there, they may still present problem and may still prevent some failure.
Okay. The question is that pointing out that some remote areas in Africa, they are so poor and less developed, will not have probably access to cold chain equipment. Actually, that's an interesting question that allow me to add some more, because we visited in Nigeria, where the public health system did not have the vaccine for the public, but the pharmacy did for $30 a piece. So went to try to buy a vaccine, and we got the vaccine out of the refrigerator, and they handed it to me to do whatever I want. So I can actually see how cold chain can fail in both scenarios. Far away, because the electricity is missing, dry ice is not available, and some other situations the vaccine can get damaged, but also can have the lack of control of the proper health authorities on the vaccine when somebody has the vaccine by yourself and bring it to you, having in your house for 3 days, and the climate is over 100 degrees Fahrenheit.
But yet your issue of polio is still a relevant one. If it was only an issue of poverty and only an issue of cold chain, then how are we ever to control any pediatric infectious diseases by vaccination in hot, poor places?
Thank you,
Is
Dr.
it
Rupe.
impossible?
Dr. Rupe is pointing out that the early comment that the big successes in polio and other childhood vaccination means that it's possible. And allow me to add a comment that it's very much not about poverty, as Dr. Rupe said. It's very much about decision and political decision to take this over your back and include it and treat it as the same as you treat the other main problems as polio, measles, or other child diseases. More questions from the internet?
Yeah, thanks, Dr. Recuenco. The first question is, do all the available vaccines, U.S. approved or not, cover all types of viruses?
Excellent question. Well, we in CDC are constantly looking for new viruses in order to respond the needs of the public to be protected from. Specifically in rabies, we are testing all the vaccines we have with any single virus or any species of the genus Lysa virus we found or we have available. I'm sorry to say that we don't have a full vaccine that protects all of them. However, there is progress in some of the manufactured vaccines covering more and more of those Lysas, and probably there will be more in the future, but at this point the most recent ones that were presented by Dr. Franca early this morning, we still are looking for additional biological. However, we have to recognize that exposure to those Lysas first adult is unknown, but we don't have suggestion that it's very extensive, like Lagos or Mokola viruses. We still are trying to find out how is that.
Are the licensed biologics, the modern cell culture biologics we have licensed in the Americas, either for humans or animals, are they protective for all the variants that we find here in the Americas?
The answer is yes. The question is, are all the biologicals available either in the US or in the Americas?
The
modern cell culture vaccines efficient to protect against all the rabies virus and any Lysa present in Latin America as we know now? The answer is yes. We don't have problems of biologicals against Lysa in this part of the world. Question?
So doctor, would you definitely recommend after exposure revaccination of a person previously vaccinated with a non-US licensed intradermal vaccine?
Oh, very nice question. Thank you. The question is that if it would be recommended, wouldn't be my recommendation, would be ACIP, would be recommended for somebody receiving intradermal vaccination from a non-approved US or WHO?
Yes, US.
A non-US
like virus.
Exactly. Well, I need to expand the information. WHO recommendation for intradermal cover Verocell vaccine, which is approved in many countries but commercially not licensed in the United States, but it's WHO approved. So that's the vaccine using intradermal. I'm not aware of any nervous tissue vaccine being administered intradermal, only intramuscular or subcutaneous, as far as I know. But if this is intradermal from an Asian country, the question would be if this person received the full PEP or partial PEP. But if it is a full PEP, I will not recommend a new administration because the vaccine is supposed to be modern cell culture vaccine. It's WHO recommended, and we have enough evidence in research and clinical trials that if properly handled, it should be okay.
Dr. Recuenco, I think, would it be possible for you to go back and review to the group the pre-exposure recommendations for two different groups of laboratory workers? The group that's involved with research that deals with high concentrations of rabies virus on a continual basis, and the group that that is exposed in a routine rabies diagnosis where they're just handling brains and not doing a lot of work with high titered rabies viruses. So can you explain the differences in
Well,
samples and
reminding the table, we have two groups. There is one group that work in laboratory. They will do rabies diagnostics, let's say CDC, let's say Washington Center in New York, let's say Public Health Department in any state, or Puerto Rico. They receive samples that are likely. Well, go ahead.
There's a difference there's a difference between routine rabies diagnosticians and those people that are doing research with high titered rabies.
Not just research.
Well, and diagnostics, but they're doing with virus, where they're doing continuous work on a daily basis, versus people in public health laboratories that are only getting brain samples for diagnosis.
Okay.
Right.
So,
Right.
if I understand what the question is, that there is some people in the lab that work daily basis with diagnostical research that have to be expected to be rabies, versus other laboratorium that might receive occasionally samples that might be rabies. So, for example, somebody working in pathology and they don't work in rabies. Is that correct? Or somebody working in...
No, there's a difference in the two groups, because some people are constantly on a daily basis working with rabies viruses.
Okay.
Then there's people that occasionally, once a month, twice a month, get an actual
What
positive
Lillian
case.
is asking is there a difference in the categorical exposure between the continuously exposed person and the frequently exposed person in regards to ACIP as per the frequency or consideration for boosters or serological surveillance?
Well, we have a difference for frequent and continuous. For continuous, the testing is every 6 months, and for frequent, it's every 2 years.
Thank you.
So the only thing that was there is that some people might not consider infrequent having once in a while when it's rabies laboratory. I would say all rabies laboratorians might receive samples regularly, and they actually have continuous about 6 months.
So do you have a high level of false positive in the in terms, because I consider that screening, and do you have a high positive, false positive?
Oh, this is a laboratory question. So you're talking about if CDC laboratory
frequent testing and also seldom testing, 6 months versus 2 years.
Okay, I don't know.
What was the question?
The question is if there is a frequent false positives in the lab, if I understood well.
When you have in terms of public health, serum testing.
Oh, this is a question on laboratory. How frequent is to have false positives in a laboratory test? Probably
For serum testing? Or
what kind of samples?
I think she was talking about serum. Were you talking about serum a while ago?
No, I was just talking about
People
two different groups.
exposed,
I just wanted to
laboratorians being
divide those
exposed
groups.
frequent
okay.
versus infrequent.
The difference is if you work with rabies virus
Right.
on a daily basis, the virus, not the rabid animal.
Right.
Okay.
Obviously, the risk of exposure of a veterinarian is much different than someone who's working with rabies virus on a daily basis. In which case, serological surveillance occurs every 6 months in those continuously exposed, particularly to rabies virus, as opposed to the veterinarian that would fall into the frequent basis, or the state public health diagnostician who would fall into the frequent basis. It's the relative risk of exposure to an animal or to the virus, oftentimes in high concentrations. It's both what, how much, and frequency that puts you into these different categorical associations, which Dr. Recuenco has explained.
Thanks, Dr. Rupert, for clarifying.
Take one last question.
Yes.
Dr. Recuenco, next question is from Ricardo Lopez in Peru, and Ricardo's question is, I saw the 1 to 5 serum dilution recommendation for antibody protection.
It's not the protection.
Is this a better recommendation than the 0.5 international units per milliliter from WHO?
Just different recommendation.
Okay, well, we are talking about rabies virus neutralizing antibodies. So the test is trying to see if there is a neutralization. So then we consider the test okay, it's at least a minimum 1 to 5. So that's what we do. So when we want to present this in international units, there is a way to convert, and those are in constant values. WHO does have a cut point 0.5 international units, and that actually is some confusion sometimes. That's actually the standard cut point for antibiotics. However, for this test, we consider that the test is adequate if there's 1 to 5.
Complete neutralization.
Complete neutralization of the virus.
There are different recommendations, and different countries can accept different recommendations from different bodies.
Yeah, that's Dr. Ruber is pointing that there will be a diversity of recommendations, lab by lab, country by country. However, the standard is, if you actually observe that the virus is fully neutralized, then you see these antibodies are efficient, and that's okay. So you don't need to.
And the important thing is there's no such thing as seroprotection. These
Okay.
are arbitrary, laboratory-defined values.
Dr. Ruber is pointing out also about the term of seroprotection. That's actually correct. In rabies, we don't have this concept of fixed protection. There is no value for protection because protection changes in dilutions in this kind of test. So while it could be a number of international units in this test and neutralized, might not be exactly the same in a different test, and also will depend on other factors related to the lab and reagent. So we found it neutralizing 1 to 5, and that's what considered that's the adequate
Complete
level
neutralization.
Complete neutralization, adequate levels of antibiotics.